80% of people living with diabetes reside in the low and middle income countries, and half of population in the world don't know that they have diabetes when they have it, and two-thirds is the number in Africa. A leading major cause of morbidity and mortality in diabetes is cardiovascular disease, and number of deaths due to diabetes estimated to be 4.2 million, and total health expenditure is 760 billion USD. So in Ethiopia, based on IDF estimates, 3.2% is the prevalence. And based on the STEP survey, which was done by faculty led by Professor Yoinareg and Dr. Adla was part of it, STEP survey 2015, 3.1% prevalence of DM and 9.2% in the pre-diabetes. And this is very significant number. If necessary actions are not taken, all of this 9.2% in the pre-DM will go to the diabetes and cause the major burden. So for cardiovascular disease in diabetes, the relative risk is 1.6 to 2.6 higher among, and it is higher among younger age and slightly among females. Each standard deviation along full spectrum of fasting blood sugar, A1C, 2 hours glucose tolerance, it leads to increment of 6 to 20% risk of CVD, and coronary artery disease prevalence is 21%, and any CVD 32% in adults from high income countries. And most of the data are coming for cardiovascular disease are from high income countries because there is a limitation in the data from the low and middle income countries. So globally, mortality related to CVD due to DM is changing. So we talk about it because this is the leading cause of mortality and morbidity worldwide. It's a cardiovascular disease, and in the US, this is the numbers you see. So IDF Atlas 9th edition has showed this summary of data for cardiovascular associations and impact of diabetes on cardiovascular diseases. The prevalence for each of cardiovascular disease, any disease 32%, coronary disease 21%, myocardial infarction 10%, and stroke 7.6%. And there is a huge increment in the risks for each of the cardiovascular disease components. And there are years of life lost, 5.8 years for men age 50 and 6.4 years for women age 50. So about diabetic kidney disease, globally, more than 80% of end-stage renal disease is caused by DM and hypertension or both, and proportion of end-stage renal disease attributed to diabetes varies between 10 and 67%, and prevalence of end-stage renal disease is up to 10 times higher in DM than without. CKD in diabetic patients in reports from the Western countries is high, as you see on the projection, and mean annual cost for DM with clinical nephropathy is 49% higher in study in USA between 1999 to 2000. So also there is an increase in the cost for patients with dialysis when compared to those with no dialysis. So there was also an increase in deaths due to CKD and DM by 94%, and 30 to 40% of patients with diabetes are expected to develop CKD. So if you see at the early phases of diabetes, there is an annual transition rate through stages of albuminuria in patients with type 2 DM. So somebody with non-nephropathy, there is a 2% progression, which is doubling to microalbuminuria annually, and there is 1.4% which dies, and then when they go to microalbuminuria, every year these numbers double, and then to macroalbuminuria, to increase plasma creatinine and renal replacement therapy, every year it doubles. So early detection and intervention and prevention of diabetic kidney disease is very crucial and important. So there is a significant loss of life due to diabetic kidney disease estimated at 16 years when no intervention are put in place. So for the etiopathogenesis of CVD and DKD, so for cardiovascular diseases, the mechanisms are known. So increased blood glucose and diabetes itself leads to cardiovascular complications through insulin resistance, inflammation, endothelial dysfunction, and toxic effects of glucose on microvasculature, and the associated risk factors of CVD like hypertension, dyslipidemia, central obesity, smoking, and low physical activity will lead and augment the causation of chronic complications of cardiovascular disease in diabetics and leads to the chronic complication pathways to the molecular ones that will lead to the occlusions and narrowing of the blood vessels. And these mechanisms on the other side are the tools for interventions and reduction of the risks. So for diabetic kidney disease, the main cause is diabetic nephropathy, but there are others that we don't often give due attention to: polyneuropathy, polyneuropathic bladder dysfunction, increased incidence of relapsing UTI, and macrovascular angiopathy in the renal artery, the afferent arteries. So this also provides opportunities to reduce risk, and this leads to the progression to end-stage renal disease through different pathways. So what are the therapeutic goals in diabetes care? These are the known goals. The patients need to be free of symptoms. They need to lead normal life, no acute complication, no delayed or chronic complication. These are the aims. So controlling 1% of hemoglobin A1C, we have learned from UKPDS that complications, all diabetes associated endpoint is when there is an increase in 1%, there is a 21% increase. Myocardial infarction will increase by 14% and stroke will increase by 12%, and microvascular complications will increase by 37%. So it is important to have that control. So for the optimization of diabetes care for every of the components, these are the basics. So individualization of care is very important. Age, body weight, complications, prevention, duration of diabetes, life expectancy, considering expense and stopping smoking, and some add also food care. So in all patients, individualization of care is very important considering these ABCDESFs. So for type 2 diabetes care to reduce CV events, these are core components. So it is a multifactorial risk reduction that works. It's not only glycemic management that helps, it is a component in it, but only controlling blood glucose will only reduce some of the risks. All the other factors like hypertension, dyslipidemia, and antiplatelet therapies are important. So this is the guideline on ADA 2020 that can be seen, and patients can be started if the blood pressure is confirmed on different measurements, more than 140/90, less than 160/100, one agent is started. If the patient is albuminuric, AC inhibitor or ARB is recommended. If not, one of the other drugs can be considered. If calcium channel blocker or diuretics are chosen, those with benefits on cardiovascular and albuminuria needs to be chosen. So two drugs can be started if the blood pressure is higher from the start and the algorithm is followed that way through. So for the start treatment, another important part that in the primary prevention in somebody diabetic age 40 to 75 years without atherosclerotic cardiovascular disease, there is a moderate intensity statin therapy in addition to lifestyle treatment. So in someone diabetic age 20 to 39, additional atherosclerotic cardiovascular risk factor is there, it may be reasonable to initiate statin therapy in addition to lifestyle therapy. And this is something that we encounter commonly in practice. Age less than 40 diabetic, maybe smoker, maybe obese. So moderate intensity can be considered for this type of patients. And DM at high risk, especially multiple atherosclerotic cardiovascular risk factors or age 50 to 75, we can consider high intensity statin. And adult disease diabetes, 10-year atherosclerotic cardiovascular risk of 20 or higher, and may be reasonable to add ezetimibe to maximally tolerated statin therapy to reduce LDL cholesterol by 50%. So the secondary prevention is well known. They need high intensity statin. Some may require addition of other anti-lipid agents like ezetimibe. And if they are not tolerated, what dose, the maximally tolerated dose of statin needs to be continued. And even in patients, older patients already on statin, reasonable to continue statin treatment in adults with diabetes aged above 75 years. It may be reasonable to initiate statin therapy after discussion of potential benefits and risks. So no consideration for pregnancy. For high intensity statin, it's only atorvastatin and rosuvastatin that has proven benefit. And for moderate intensity statin, all the others are in the list. So antiplatelets are also important in reduction of cardiovascular risks in diabetes management. So in the renal outcome also, the same screening and identification of the renal problem, optimization of glycemic care, and managing significant proteinuria and managing hypertension and managing dyslipidemia is also important to optimize renal outcome. So these patients for diabetic kidney disease, especially type 2 diabetics, while they are on follow-up, have to be screened yearly for urinary albumin and type 1 after 5 years of diagnosis. So patients with urinary albumin above 30 should be monitored twice annually to guide therapy, and optimization of glucose control is extremely important. So this is what we are going to talk about in a moment, type 2DM and diabetic kidney disease. So SGLT2 inhibitors in patients with an estimated GFR above 30 and urinary albumin above 30 milligram per gram of creatinine, particularly in those with urinary albumin more than 300, to reduce risks of CKD progression, CV events, or both. So those with CKD who are at increased risk of CV events, use of a GLP-1 agonist may reduce risk of progression of albuminuria, CV events, or both. So blood pressure has to be controlled. So for minor elevation of creatinine, there is no need to discontinue RAS, renin angiotensin system blockade is not required. And so for people with non-dialysis dependent CKD, dietary protein intake has to be to the daily allowance, and on those on dialysis, it is allowed a bit higher. And in non-pregnant patients with DMN hypertension, either AC or ARB is recommended for those with modestly elevated urinary albumin to creatinine ratio, and is strongly recommended for those with urinary albumin to creatinine ratio, and periodically monitoring serum creatinine and potassium levels for the development of increased creatinine or change in potassium when AC inhibitor, ARBs, or diuretics are used. So if someone is not hypertensive or they don't have proteinuria and normal EGFR, there is no need to start AC inhibitor or ARB. And it's important to refer patients to the nephrologists with lower GFR when there is diagnostic difficulty, when there is a need to consultation, even if the GFR is not less than 30. So what are review of evidences for cardiovascular and renal outcome studies of newer anti-hyperglycemic agents? So these are the two groups of drugs which are now being talked about a lot in the studies, and the researchers have showed something which is very amazing and interesting. And these drugs have gone beyond being only anti-hyperglycemic agents to cardiovascular and renal outcome improving drugs. So diabetes is known to be caused by type 2 diabetes by different etiologic and pathophysiologic mechanisms. This is what we call the omnious octet. And of this today, we are going to focus on increased glucose reabsorption through the kidney and GLP-1 receptor agonists, which is produced from the small intestine. So ADA and the authorities in the diabetes care has reviewed the guidelines and looked into the risk factors, not only just the blood glucose values. So in somebody with established atherosclerotic cardiovascular disease or CKD, they considered for atherosclerotic cardiovascular disease predomination GLP-1 receptors with proven CVD benefits and or SGLT2 inhibitors with proven CVD benefits within acceptable eGFR. So for those with heart failure or CKD, predominantly, preferably SGLT2 inhibitors with proven benefit, or as if SGLT2 inhibitors are not tolerated or contraindicated because of GFR, then GLP-1 receptor agonists are recommended. So the algorithm goes on to other considerations also, like compelling hypoglycemia to minimize it, weight loss or minimize weight gain, or cost is a major issue. So cardiovascular safety trials within these newer classes of agents have started since 2008, following the rosiglitazone effect and following the tragedy for the rosiglitazone, which was withdrawn from the market because it has increased the mortality. But following those studies, there was significant findings that have shown some of the anti-hyperglycemic and diabetes medications have showed significant improvement in other cardiovascular outputs. So the list goes on from 2013 to 2021, and there are others also in 2022. So SGLT2 inhibitors and cardiovascular outcome summary. So canagliflozin, dapagliflozin, epagliflozin, and ertogliflozin. These are the 4 drugs which are well studied in the SGLT2 inhibitors category. And as you see, canagliflozin has significant reduction for major adverse cardiovascular events, heart failure, hospitalization for heart failure, nephropathy, and CV days was neutral. And dapagliflozin has reduction in heart failure, hospitalization, and also nephropathy. And empagliflozin, as you see, has reduction and improvement outcome across the spectrum. And ertogliflozin was safe to be used, but it is non-inferior to the placebo to which it was compared to. So when we talk about these drugs and we compare them, there were heterogeneity in the patient populations who were studied in these studies. For the IMPAREG outcome study, all of the patients were those patients with cardiovascular diseases, established cardiovascular diseases. And for CANVAS program, 34% are primary prevention patients with risk factors, established risk factors, and 66% were secondary prevention patients with established cardiovascular disease. And in the declared TME, it is almost the opposite of the CANVAS program, where the primary prevention is 60 and secondary prevention were 40% of patients. So when we compare them, we need to know these facts in mind. So IMPAREG outcome, the population with type 2 DM and established cardiovascular disease. So these patients is almost like 10 to 15% of patients with cardiovascular diseases or with cardiovascular risks in these studies, they have heart failure. The vast majority of these patients, they don't have heart failure on recruitment. So if the study showed there is an improvement in heart failure, this means that these drugs are preventing the onset of heart failure, or in that category of patients with heart failure, they are improving the progression of heart failure. So the meta-analysis and the sub-analysis was done looking into heart failure, history of heart failure before admission, before hospitalization, and CV days. So in hospitalization for heart failure, those with no history of heart failure has significant benefit. As you see, the line favors the empagliflozin, and for those with CV days also, there is a benefit for those patients with no heart failure. So those who benefited from CV days with no history of heart failure, they benefited in that category of 90% of patients. Even for those with history of heart failure for CV days and hospitalization for heart failure, there is a trend towards protection from heart failure, even though the line is crossed. So for hospitalization for heart failure, Imparec has a reduction of 35%, Canvas and Canvas are reduction of 33%, Declare TIMI reduction of 27%. This is robust, and this is very significant improvement in patients' outcome. So for major adverse cardiovascular events in this meta-analysis, you see there is a favoring the study drug, which is empagliflozin in overall fixed effect model. There is favoring of these drugs. This is primarily a cardiovascular outcome study. And treatment effect on MI by the presence of established cardiovascular disease. So with established cardiovascular disease, the overall benefit is seen for MI in the established cardiovascular disease group, but with those with multiple risk factor, there is a trend towards it, but it didn't show significant. It's almost one. For the treatment effect on cardiovascular deaths by the presence of established cardiovascular disease also, the benefit is more significant for those with established cardiovascular disease, as you see for the fixed model effect, but with multiple risk factors, the benefit is not different. It is, at least it didn't increase, but it is not as those with established cardiovascular disease. For hospitalization for heart failure by the presence of established cardiovascular disease, this is where we see the significant benefit in all of the studies. So empagliflozin in all of the three randomized control trials with empagliflozin, canagliflozin, Declare TIMI, we see the significant benefit for those with established cardiovascular disease and also with multiple risk factors. So these are drugs which are really beneficial in preventing and reducing cardiovascular heart failure. So also they looked into whether prior heart failure in those hospitalized for heart failure has difference. So as I said earlier, approximately 90% of patients are without heart failure. So in this category also, in those with history of heart failure, in those with no history of heart failure, there is a significant reduction in risk of heart failure in this sub-analysis. So overall, for redefining this pathway to cardiorenal and complications of type 2 DM, the traditional focus, increased lipid, increased glucose, increased blood pressure, and thrombotic tendency, and increase endothelial dysfunction. And there is a novel insight in type 2 diabetes and obesity with increased insulin, increased renal glucose expression, increased glomerular hyperfiltration, tubuloglomerular feedback, and some other mechanisms through sodium and glucose retention, intravascular volume expansion, which lead to increased volume status, hemodynamic, and glomerular stress, leading to kidney disease, heart failure, and also the older mechanisms through accelerated atherogenisis, so by MI, CVA, and PAD, lead to worsening of cardiac and kidney condition. So one of the novel and mechanism which is identified in the benefit of these SGLT2 inhibitors is this blockade of the sodium hydrogen exchanger by SGLT2 inhibitor. When this sodium hydrogen exchanger 1 is blocked in the cardiac myocytes, the amount of calcium within the myocytes will decrease, and that will help the survival and decrease in cardiac injury for the myocytes. And also in HE3 in the kidneys, this leads to increased sodium excretion, decrease in body weight, and decrease in blood pressure, hemoconcentration, and this leads to decrease in cardiac wall stress. So SGLT2 inhibitor and cardiorenal protection, these are the potential mechanisms, direct effect on sodium hydrogen exchange, adipokines, reduction in fibrosis, and improve ventricular loading conditions through diuresis, natriuresis, after load reduction, myocardial energetics and metabolomics, and direct effect on myocardium and transforming growth factor, a reduction in intraglomerular hypertension. So declare TME 58, other than the previously mentioned benefits in heart failure and CVDs, it also showed the reduction in atrial fibrillation and atrial flutter. So it is significant. As you see, hazard ratio is 0.81, which means 19% reduction. So atrial fibrillation and atrial flutter outcomes by major subgroups, whether they have history of atrial fibrillation or atrial flutter, there is a benefit. For atherosclerotic cardiovascular disease versus multiple risk factor, there is a tendency toward the benefit, and history of heart failure also, there is a tendency towards benefit in declared TME 58. So this is a very important study, which is DAPA heart failure study, which has involved also patients who are not diabetic. And what was found in this study was the primary composite outcome of cardiovascular death, heart failure hospitalization, and urgent heart failure visit. Dapagliflozin has a significant reduction in the cumulative percentage with hazard ratio or with risk reduction of 26%. And also for primary composite outcome, CVDs is decreased within first 100 days. So for the worsening components of primary outcome, worsening heart failure events, dapagliflozin has significant reduction for worsening of heart failure events and also cardiovascular diseases with significant risk reduction. 18%, 30%. So this is very important. Numbers are very clear here. For those patients with diabetes, the primary composite outcome for risk reduction for CV days, heart failure hospitalization, urgent heart failure visit, there is a 25% reduction. And also for non-diabetic, there is a 27% reduction in primary composite outcome in this group of patients. So effect of dapagliflozin according to age categories across the spectrum of age in this dapagliflozin, DAPA HF, there are benefits in those more than 55 years. So based on this finding, this was a study which was done in patients with heart failure with reduced ejection fraction. FDA has given approval for dapagliflozin, Farxiga, oral tablet for adults with heart failure with reduced ejection fraction to reduce the risk of cardiovascular death and hospitalization for heart failure. So this is in class 2 to 4 heart failure with reduced ejection fraction. So there are ongoing trials for SGLT2 inhibitors in heart failure. There is Emperor Preserved, those patients with ejection fraction more than 40, and the primary endpoints are CV days or heart failure hospitalization, and these are patients without and with diabetes, and emperor reduced. This is also empagliflozin with reduced ejection fraction. Deliver is for dapagliflozin with reduced ejection fraction, and GFR more than 25 with CV days or hospitalization for heart failure or urgent heart failure visit. And impact MI is empagliflozin in patients with MI. So there are ongoing studies to look into patients with preserved ejection fraction and also patients with reduced ejection fraction in those drugs which are not explored yet. So SGLT2 inhibitors shows reduction in adverse cardiovascular outcomes in type 2 DM, and dapagliflozin reduced CV days, heart failure, hospitalization, and symptoms burden in patients with established heart failure with reduced ejection fraction and with and without type 2 DM, and more to be learned from ongoing trials of SGLT2 inhibitors are HFrEF and HFpEF studies to come out. So prior to credence, now we are going to the kidney part. There are these studies, these are heterogeneous, and as I said earlier, the Declare TIMI 58 Canvas program, empiric outcome studies. So there are different cutoff points which are used. GFR at enrollment, Declare TIMI is more of, as you see, more than 60. Canvas and empiric are more of those with reduced estimated GFR. So empiric for the renal analysis have showed also significant reduction in post-hoc renal composite outcomes. Serum creatinine, renal replacement therapy, and renal days was significantly decreased by 46%. A long-term stabilization of EGFR was noted in this group. New macroalbuminuria reduced by 38%. Long-term stabilization, as I said, new onset of worsening nephropathy reduced by 39%, doubling of serum creatinine decreased by 44%, and empagliflozin provided similar CVD benefit in patients with EGFR more than or less than 60. So in the Declare TIMI 58 renal outcome, there is also improvement in the composite cardiorenal outcomes with improvement, risk reduction of 24%, and composite renal specific outcome also, and sustained confirmed reduction in EGFR, which is protective, and changes in EGFR over time was also stabilized. So in the meta-analysis of SGLT2 inhibitors trial on the composite of renal worsening in stage kidney disease or renal disease stratified by the presence of established atherosclerotic cardiovascular disease, as you see, overall in patients with atherosclerotic cardiovascular disease, there is a significant benefit. And for patients with multiple risk factors also, there are significant benefits in these programs. So renal data from CVOT, even though these have shown significant benefits, they were not designed to study the renal component, the renal outcome data, but they have showed significant findings. So we can say they are hypothesis generating. Outcomes varied along the spectrum by strictness, by design, and credence tells concrete data about renal protection. So Declare TIMI 58 is mostly preserved, as you have seen, with EGFR more than 60, and still seems to delay CKD progression, and unlike credence and DAPA CKD with lower GFR. So analysis were done for different components for kidney failure, stratified by basal EGFR on the right side. They have all showed overall benefits by EGFR and other components. And also, when they are stratified by urine albumin creatinine ratio, you see overall there is a benefit from those early studies of cardiovascular outcomes. And they looked into baseline hemoglobin A1C subgroups, those with less than 8% of hemoglobin A1C, more than or equal to 8%, in those with proven cardiovascular disease, and in those with renal outcome per hemoglobin A1C stratum, they were found to be beneficial. So this means these drugs are not only for blood glucose control, they have benefits beyond blood glucose control on renal outcomes and as well on cardiovascular outcomes. So coming to credence, this is a study design. It is a double-blind randomized controlled trial, and the primary outcome is composite of end-stage renal disease, dialysis, transplantation, or a sustained estimated GFR of less than 50, and pre-specified secondary outcomes were tested hierarchically, and these are the main results. There is a robust finding. You can see how significant is this p-value with 30% lower in the canagliflozin group, and for relative risk for primary outcome, and for the renal specific composite of end-stage kidney disease, doubling of creatinine level, or death from renal death, also a very robust and significant finding in the credence study. And for MACE also, lower risk of CV death, MI or stroke, hospitalization for heart failure, it was very significant finding across the study. So these figures speak for themselves. Primary composite outcomes, significant reduction of 30%, and also renal specific composite outcomes, significant reduction of 34% in these studies. In the stage renal disease also is significantly reduced. Even those patients with less than 30 have benefited from this study who are undergoing dialysis. And summary for forest plots of the credence showed significant benefit in multiple components. So there are the thought adverse events early on were not seen very much in credence, probably because people have learned how to handle these patients, how to manage them. Even male genetic female and male mycotic infections were not increased in credence, and there was no difference in amputation with canagliflozin, unlike previous reports. So there are other SGLT2 trials with renal outcomes. Vertis, that is the ertugliflozin I referred early on to. It is non-inferior to the placebo. DAPA-CKD stopped early due to overwhelming efficacy in the renal outcome, and SCORD was terminated because of issues with the sponsor, and IMPA kidney is to be reported. So renal dosing information, these are informations which are now in the leaflets, in the package inserts. These are probably going to change as some of the eGFR values following these studies might be going to change. So overall, this is what we have gone through. SGLT2 inhibitors are beneficial through glucosuria, natriuresis, and other multiple mechanisms. They have cardio and renal protection activities. So few points on Hp1 agonists. These are drugs which are resistant to DPP4 action, and they have prolonged duration of analog action. These are GLP-1 analog or agonists. So this is what we call the incretin effect, this which is hampered or decreased in type 2 diabetes. So when somebody takes oral meal, there is an increase in plasma glucose. There is an increase in insulin as well concomitantly, but that does not occur in individuals with type 2 diabetes because of decreased incretin effect, which means because of decreased production of GLP-1 from the gut intestinal cells. So they have different actions and mechanisms of actions: glucose influx from GI tract reduction, insulin resistance improvement, inadequate glucose suppression, alpha cell dysfunction. that is improved by these drugs, and maybe they improve beta cell function, and maybe also they improve chronic beta cell function. So this is the finding from leader trial on liraglutide, which is a GLP-1 analog injectable, and it has showed significant benefit for primary outcome of cardiovascular mortality, non-fatal MI, non-fatal stroke, with a reduction of 23%. And deaths from cardiovascular deaths also, you see, it is decreased in this liraglutide trial. A non-fatal myocardial infarction is also decreased, but not significant. Non-fatal stroke is also decreased, but not significant. Death from any cause is significantly decreased in this study. Hospitalization for heart failure is decreased, but it is not significant. So this is a significant finding for the liraglutide. And the other one is SUSTAIN 6 study for semaglutide, which has a significant reduction for primary outcomes, composite outcomes, both for non-inferiority and for superiority. So that is why this is a cardio CVD protective and beneficial drug. And non-fatal myocardial infarction is decreased but not significant. Non-fatal stroke is significantly decreased, and deaths from cardiovascular cause is almost similar. For renal outcomes, they did leader secondary analysis. It has showed also significant benefit for composite renal outcomes, doubling of serum creatinine and reduction in EGFR and so. And new onset persistent macroalbuminuria was significantly decreased. Doubling of serum creatinine was also significantly decreased when looked into separately. And the continuous renal replacement therapy was also decreased, but it was not significant. So there is another drug in this group, which is also showed some benefit, exenatide, extended release. So GLP-1 agonist is proving cardiovascular renal outcomes. The beneficial ones are liraglutide more than semaglutide more than exenatide extended release. For congestive heart failure, these GLP-1 agonists are neutral. For progression of diabetic kidney disease, liraglutide has showed reduction in the progression. So coming to summarize it, patients with cardiovascular disease, atherosclerotic disease, ADA recommended for the hypertension to continue ACE or ARB, and beta blockers if they have at least 2 years after the event of MI. Type 2 DM with stable heart failure, metformin can be continued. Type 2 diabetes with established atherosclerotic cardiovascular disease or established kidney disease, SGLT2 inhibitor or GLP-1 receptor agonist with demonstrated CVD benefit is recommended as part of the glucose lowering regimen. So these are recommendations are based on those study findings that we have already presented. Type 2 DM and established atherosclerotic cardiovascular disease, multiple atherosclerotic cardiovascular risk factors or DKD, SGLT2 inhibitor with demonstrated CVD benefit is recommended to reduce the risk of major adverse CV events and heart failure hospitalization. And those with atherosclerotic CVD or multiple risk factor for atherosclerotic cardiovascular disease with no heart failure, with no CKD, GLP-1 agonists are recommended. Type 2 DM and established heart failure, SGLT2 are the drugs of choice. So most of the authorities to date recommend these drugs to be used following metformin, even if the patient has heart failure or CKD if they are not contraindicated. But in 2019, European Society of Cardiology with EASD have made this recommendation. In someone who is newly diagnosed or drug-naive patient with type 2 DM and had atherosclerotic cardiovascular disease or high or very high CV risk patients, they recommended SGLT2 inhibitor or GLP-1 receptor agonist monotherapy. And for those on metformin, as add-on treatment, if they have atherosclerotic cardiovascular disease, the recommendation is made to add SGLT2 inhibitor or GLP-1 receptor agonists. So there is a move forward in this authorities' recommendation based on the evidences that are accruing from the randomized controlled trial, which are very convincing, and we maybe in the near future these same recommendations will be adopted by the other authorities as well. So in summary, diabetes is increasing at a pandemic level. Leading cause of death in diabetes is CVD disease, and optimization of care following the current recommendation is needed to decrease CVD and renal risks and deaths. Some of type 2 diabetes medications, GLP-1 receptor agonists and SGLT2 inhibitors, are now beyond blood glucose controllers. So thank you, Dr. Dijuma.
Thank you, Dr. Abdurezak. It's a very nice presentation and summary of an emerging issue in diabetes and cardiovascular disease. So I think this will help us in managing our patients, in choosing most beneficial drugs among the long list of drugs for treatment of diabetes and cardiovascular disease. And having said so, we'll take few questions and comments because we have run out of time. If I start, you know, the benefits of these drugs has been mentioned in most type 2 diabetes patients. And what is the extension to our patients who have type 1, which is also common in our country, and also in difficult situation where it is at times to differentiate type 1, type 2 diabetes patients, especially SGLT2 inhibitors. What's your opinion?
Hello?
Thank you, Dr. Dijuma, very much. Somebody talking?
Just so.
Yes, okay.
So
please proceed, Dr.
type. So let me respond to this one, and then I will take the other question.
Okay. Okay.
These drugs, SGLT2 inhibitors, are not approved for type 1 diabetes. One of the side effects of the drugs is there is an increased risk of diabetic ketoacidosis. So for type 1 diabetes, they are not approved, and even there is a risk of diabetic ketoacidosis, even though it is very rare. If anyone with type 2 diabetes have developed diabetic ketoacidosis or ketoacidosis, these drugs has to be discontinued and they should not be given. So for difficult ones to differentiate between type 1 and type 2, so we will not risk them to be given these drugs. We will go the standard ways, because if this is type 1, it will be difficult to introduce.
Okay.
But for
Thank
those
you for
like ketosis-prone diabetes, once we control with insulin, these drugs can be used. That is a common finding in our setting. Ketosis-prone diabetes in adults, type 2 patients who come with ketosis, obese ones, do well after few period of insulin on metformin, then these drugs can be used.
Thank you for the clarification, Dr. Abdurezak. Professor Wainarek?
Hello, Dr. Dijuma, can you hear me?
Yes, yes.
Well, again, good morning, everyone. I just want to say a few comments. I would like to congratulate Dr. Abdurezak for excellent and very inspiring presentation. And he has gone through the details of the clinical trials, that is the current science available worldwide. So I just want to say only a few points on the terminologies. Like currently there are new terminologies. The new terminologies are like calling chronic cardiorenal syndrome or chronic renocardiac syndrome. These are really alarms us. The association between in a diabetic patient, the involvement of cardiac and renal disease is very, very important because of its morbidity and mortality. So what I want to say is when we look at the degree, the CKDs 1 to 5, the risks of this deterioration are clearly identified depending on the stage, and like smoking, obesity, hypertension, dyslipidemia, chronic inflammation, like anemia, uremic factors, and calcium phosphates abnormalities. All the inflammations related to cytokines, chemokines are really devastating, and all these risk factors cause damage to the heart and leads to decreased cardiac output, and at the same time it causes subclinical inflammation, endothelial dysfunction, and accelerated atherosclerotic. And in addition to that, there are genetic factors. Whenever we talk of diabetic retinopathy, we should not deny of genetic risk factors which involves in pathogenesis. So there are genetic risk factors, acquired risk factors, and a decreased cardiac output has an impact on chronic hypoperfusion to the kidney. So what will happen then is there is increased renal vascular resistance and venous pressure. And in addition to that, all this leads to sclerosis, fibrosis, and apoptosis of the kidney. This is the current problem which we have to really realize. So whatever cardiorenal or renocardiac syndrome, the outcome of the problem is this. So in order to halt the progression, Dr. Abdul has clearly showed us the interventions on management of type 2 diabetes mellitus, but currently the role of SGLT2 inhibitors, there is a class effect of this drug, protecting the heart, protecting the kidney. I'm not going to go back to the clinical reviews, it's well described. So we have to keep this in mind. This drug has a renoprotective and cardioprotective effect. The studies are well described. In addition to this, the GLP-1 receptor agonists are also beneficial. Already we have seen the advantage of these drugs. So oral GLP-1 receptor agonists are now available, like semaglutide. And one other important point here is the combination of the two drugs, the GLP-1 receptor agonist and SGLT2 inhibitors. If you combine both drugs, our patient will benefit from that. But how far these things are practical in our setting remain a question. So thank you very much. Again, I would like to thank Dr. Abdul for such a great presentation. Thanks, Dr. Dajum.
Okay, thank you, Prof, for the addition in the comments. Any burning question, because we still have a few minutes? Dr. Dufera, okay.
Yeah. Thank you, Dr. Abdurezak, for an excellent presentation. And these are the landmarks in the management of cardiovascular disease. I will not go to the new drugs, but I will just ask you about the old drug. How do you see aspirin in primary prevention when you compare with bleeding risk and final outcome benefits? Actually, in type 2 diabetes.
Thank you, Dr. Dufera, for this question. So aspirin nowadays, there is an increased risk of bleeding from aspirin, as it has been known in previous days. In old days, it has been recommended almost across the board. But now, especially in older patients, it is unless there is an increased risk, we don't go for aspirin. But it may be considered as a primary prevention strategy in those with diabetes who are at increased risk of cardiovascular diseases. So that has to be discussed with the patients, and the benefit versus the comparable increased risk of bleeding should be explained for the patients. So nowadays, other than aspirin, intensifying other like statins, controlling hypertension, controlling blood glucose, might play a very important role in reducing the risks.
Okay, Thank you.
Thank you.
Yeah, there is no strong indication except in those patients who
Yes.
had previous atherosclerotic cardiovascular disease. But class 2
True.
indication may be for those older than 50 years with additional one risk factor for atherosclerosis and no bleeding risk or very minimal bleeding risk. Okay, this is a class 2 indication currently. Maybe one last question is about antihypertensive. It's, you know, in our common practice, people usually start with ACE inhibitors. You know, the blood pressure control with ACE inhibitors, especially for blacks in our country, patients from our setup are less. And so it is important to know that, as you have stressed, a patient with proteinuria and patient who has got CKD should be given ACE inhibitors as the first initial choice. Otherwise, one can start with calcium channel blockers. Right away, patients are started on ACE inhibitors, and so this has an implication in control of blood pressure.
Thank you, Dr. Dujuma. You have answered it, and that is true. That for controlling the blood
Yes.
pressure, ACE inhibitors are,
Hello, if you don't have further questions, yeah, proceed, please.
you know, if there is no indication, no proteinuria, no other indication to use it, calcium channel blockers do better for us, for Africans, for blacks in general, maybe diuretics, also with proven benefit, as I have said. Then otherwise, if there is proteinuria, we can go for angiotensin receptor blockers or ACEs. Thank you.
Okay. Thank you all for the active participation. It was really an amazing presentation, and I thank you, and we'll stop the presentation.